A very good afternoon to you all. And to start with, it will not be a exaggeration to say that the management of the chemical ocular injuries in pediatric age group is a real workout. As far as management of it is concerned, the large number of treatment modalities may need to be involved in it. Not only anterior segment cornea, but also pediatric glaucoma, vitreoretina, and even active participation of anesthesia and critical care. The pediatrician, immunologist, and rheumatologist all may have to chip in for the final and to get a better and final outcome. As far as approach for the assessing of the chemical injuries particularly in the emergency room is concerned, we have to go for the four-pronged approach. First of all is to ascertain whether it's a chemical injury. As children are aware, poor history tell us, as it has already been brought by Dr. Jaya very well. Then to observe any other associated collateral injuries which may skip our attention and may be critical, like airway and head and neck. Assess the ocular involvement. This assessment is just a visual assessment, so as to we have to quickly assess and decide, as time is very imperative and critical. The type of injury in it, what type of chemical, either alkali or acid, as theory goes, the alkali injuries are considered to be severe. However, the data has and the studies have come out, there is no much difference between the alkali as well as acid injuries as far as outcome as well as prognosis is concerned. In the emergency management, the removal of the corrosive agent comes the foremost. As the chemical interacts with the tissue, the proteins break down, low molecular weight fragments do come in and they act like chemoattractants, and they also play a part of the inflammatory mediators. Irrigation, therefore, is the foremost. It has to be done within seconds with a copious amount of irrigation. 2 to 8 liters is written out here, but further can also be required. It all depends upon how the pH is turning on, because we have to keep an eye over it to make it as neutral as possible using litmus papers. And if it is not there, the urine pH strips can also be utilized in these cases. We have got multiple modalities to use. Morgan lens, definitely, it's a very handy device, has also been used in children, and children are also quite comfortable with it. It has been used in the cases as low as 6 months children. However, it's not quite so easily available as far as we are concerned. I have myself not seen this kind of a device ever. So the conventional other way are using IV sets, nasal cannulas, or undines. Those have become quite historic as of now. As far as the mechanism goes, it's very simple. It changes the pH to neutral, but it's not only the surface. It is the anterior chamber pH as well. It removes the chemoattractions, inflammatory mediators, and dilution of the corrosives also do come in. Neutralization may also take place. However, the buffers, if added, does play this neutralization role. Do we really need to select the irrigation fluid? As far as emergency is concerned, there is no question of selecting. Whatever is handy available, it has to be used. Some of the anecdotes have also mentioned milk, which has also been used in the emergency situation. However, in the hospital scenario, we have got an array of irrigating fluids out of which to choose. It has got all do have some advantages and disadvantages. However, as far as clinical scenario goes, dafoterin, which are the polyvalent amphoteric solutions, comes the foremost. However, they are not so easily available. BSS plus, BSS, ringalactate, and normal saline with soda bicarb are also being utilized. Once the child has already been taken into an OR or quite cooperative to get examined, we look for the retained embedded particles. Deliberate look is important as well as the sweeping of the fornices to find any embedded particles which needs to be physically picked up or mechanically scraped. This is the time now to evaluate and classify the injuries. We have to look for the eyelid injuries, the corneal stroma, which in the form of haze or edema, stolophytes, or any thickening or melting. Staining is important as far as corneal surface is concerned. Conjunctiva, which up to the fornices has to be seen, along with the limbus, which is very critical. Limbus shows pale areas or edema, hemorrhages, abruptly terminating necrosis, and abruptly terminating vessels. They all do come under the classification of limbal involvement. rather than just a limbal ischemia. It can be classified based on any either Roper Hall classification or Dua's classification. However, in the Dua's classification, this conjunctival involvement does be maybe very critical as far as children are concerned, and they have a very small area of conjunctiva, as the eyes are small and they are growing, and even a small amount of spillage can involve a large percentage of conjunctiva, and thereby leading to symplepharon formation as well as ocular surface problems. The analog scale is quite unique to Dua's classification, and the grade 4 of Roper Hall has been divided into further subclassified into 3 more subheadings, which can be more very important as far as child chemical injuries are concerned. However, the precise assessment can only be done on the photographs, FA or OCT angiography, which may be feasible in the elder children. The reassessment definitely has to be done at multiple stages. Recurrent examinations has to be carried out, as lingual ischemia takes precedent in classification of the grade. The additional evaluation is involved the AC, lens, retrolental, retina, and even the IOP. The objectives of the treatment will be the control of inflammation, promote epithelial healing, support repair, and prevent complications. The acute injury targets will be inflammation, epithelial defect, limbal ischemia, and collagenolysis. The basic the inflammation, which is being controlled by topical steroids, epithelial defect, which may require surgical intervention like BCL, amniotic membrane grafting, tarsorrhaphy, and even symplepharon rings. Limbal ischemia definitely again requires a majority of the surgical interventions which do help in it, mainly tenoplasty, tenon advancement, amniotic membrane grafting, and conjunctival flaps. However, collagenolysis also to be targeted, which based mainly upon the topical treatment, basically topical citrate, ascorbic acid, even oral ascorbic acid has to be given. Role of tetracyclines is definitely contraindicated in the less than 9 years of age group. IOP also does have to be controlled. As far as the final outcome is concerned, the main outcome depends upon the corneal opacity and the surface irregularities, which later may be surgically controlled. To conclude, the outcome may not parallel as the results. The fast pace of the healing response abridges each phase, and we as a ophthalmologist need to keep pace. And generally, the prognosis in these cases are quite poor. Thank you.